Welcome to Mental Health Playbook, Clinical Psychologist, Common Rejections and Denials. My name is Mary Muko. I am a member of the WPS Provider Outreach and Education team, and I will be your presenter today. Joining me is my friend and coworker, Karen Curtis. Karen is going to be helping me today by monitoring the chat and providing you with additional information and links. Now, if you've been checking out our live events webpage, you may have noticed multiple webinars beginning with the words Mental Health Playbook. These sessions are designed to give an entry-level introduction into Part B mental health. And when I say Part B mental health, I'm talking about those providers that bill on the CMS 1500 claim form. Previous sessions can be found on our Encore Presentations webpage as well as on our YouTube channel. Listening to those previous sessions is not something that is required to understand what I'm going to be covering today. I just wanted to make you aware that that additional education is available. Our objective today is for learners to receive an entry-level introduction to Part B Medicare, original Medicare outpatient mental health. So today's focus is actually data-driven. The topic is Part B Clinical Psychologist, Common Rejections and Denials. This agenda, what you're seeing here on this slide, should look very familiar. This is the exact topics identified in our webinar description. This is what you would have seen when you registered for today. So these items specifically are what I'm going to talk about in the next 60 minutes. Today's session is not designed as a question and answer session. Rather, during this session, I am going to define rejections and denials. I'm going to reveal the most common reasons why WPS rejects and denies claims that are submitted to Medicare, to WPS, that is your MAC, by clinical psychologists. So it's specialty-specific data that I analyzed and I'm presenting during this webinar today. I'm going to share with you some ways you can fix and avoid both the rejections and denials, and of course I'll be providing you with many resources. So let's get started. A Medicare remittance advice, sometimes referred to as an RA. Some people even call it the notice, or maybe even shorten it up to the word remit. This is a notice that is sent by Medicare Administrative Contractors, or MACs, to healthcare providers, and it explains the claim rejections or the adjudication of claims, and this would include payments, adjustments, and denials. The remit includes codes that explain why a claim rejected or denied or partially paid. Now, it also lists any amounts applied to deductibles or the copayment and reductions made to that particular claim. Most providers do receive an electronic remittance advice, with only a few remaining that receive the standard paper remittance, and providers can use self-service tools to access additional claim information, including those helpful reason and remark codes that I talked about earlier. We do have a reason and remark code lookup feature on our website. Other tools to look at and define what's on that Medicare remit are our SecureNet Access portal. That is the secure side of our website where you can look at how a claim processed. There's also the interactive voice response, or the IVR system, that can be used to provide additional details about your rejections or your denials. And I've embedded links to all of these on your handout materials. So first I'm going to talk about rejections, and I used to have these both on the same slide, and I thought it would be best really to separate them because they really truly are different things. And a lot of us, even myself, I catch myself doing this all the time, and then I have to correct myself. I use the words interchangeably, a rejection and a denial, but they really are very different. Let's talk rejections first. Rejections are unprocessable. That is a word used by CMS. It means the claim is rejected. It's returned on what we like to call the front end. It's not adjudicated. The reason why we and other MACs reject claims is because something's illogical. It means something's missing, something's incorrect. There are no appeal rights if your claim is rejected. The reason is because it's not ever adjudicated. What you need to do is fix it and resubmit it. There's a clue to the fact that a claim is rejected when you look at your remittance advice, because you will see a remark code MA130 and a group code CO16 that appear on that remittance advice. For rejected claims, the patient is never liable because what you need to do is fix it and resubmit it. Denials, on the other hand, are claims that are adjudicated. And we deny claims for a number of reasons, some of which are listed here on this particular slide. That you'll see that first sub-bullet is statutory requirements, and that means that there's a law that means Medicare can't pay for the item or service. Statutory means law. Another reason why we might deny a Medicare claim is that it might not meet Medicare's coverage requirements or medical necessity. Sometimes services will have a utilization parameter or a frequency parameter, meaning, for example, Medicare will only pay for this item or service once every 6 months. That's called a frequency denial, and a frequency denial really equates to medical necessity, and medical necessity equates to policies. Okay, so typically there would be a local or a national policy that it would explain medical necessity for an item or service. Remember, from medical necessity denials, including those frequency denials, those are those situations where you may want to consider presenting your patient with that advanced notice of non-coverage or advanced beneficiary notice of non-coverage, also known as the ABN. Remember, you need to do that in advance, and you need to be clear why you believe the likelihood that Medicare will deny the service is not medically necessary in order for you to report a modifier on your claim and move that liability over to the patient. For most denied services, not all of them, there's a couple of exceptions, there will be an MA01 code that provides appeal rights on that remittance advice. And of course, for denied services, just as I mentioned a little bit ago, patient liability would be determined. It depends on the use of those modifiers, if you presented your patient with an ABN, if it's applicable to do so, and so on and so forth. So again, that would vary from claim to claim. Now, there are potential actions to choose from to fix or avoid these denials and rejections in the future. A rejected claim, those that CMS calls unprocessable, those need to be fixed and resubmitted. But for a denied claim or claim line item, there could be multiple actions to choose from. Like a rejected claim, you may be able to fix the error or resubmit the service. You might also want to consider using the clerical error reopening or CER process to have the denied service adjudicated. You might also choose to request an appeal. For the latter two options, we really do suggest that you consider using self-service options, which for you and WPS providers is the SecureNet Access Portal, as this is the self-service tool that offers the most expeditious way to receive a Medicare partial or full payment. All right, I've defined rejections and denials. Next is the data. CMS requires MACs to utilize data to determine our education strategy. Our data specialists have created a dashboard, so those of us in provider outreach and education, sometimes we call it POE, P-O-E, so we can analyze the claim submission, rejections, and denials and determine education needs. And just as advertised, today during this webinar, I'm going to reveal the most common reasons why WPS rejects and denies Part B claims for clinical psychologists. Those are providers that are assigned a 2-digit specialty code of 68 when they successfully enroll in Medicare. Now, specialty codes, for those not familiar, are Mostly self-designated during the Medicare enrollment process, but some are not. Some providers choose to report a secondary or tertiary specialty. However, only the primary specialty code is used during initial claim processing. So this slide lists the data slicers or filters that I use to pull rejections and denials data for clinical psychologists in our claim processing jurisdictions 5 and 8. Now this means Part B claims, those submitted on a 1500 claim form for Iowa, Kansas, Missouri, Nebraska, Indiana, and Michigan. The dashboard that the Insight team prepared for us in outreach provides 3 months of claim submission dates at a time. And each month, the data analyst will load a new month of data and they remove the oldest of the 3 months of data. And that said, the claim submission data for the data that I'm about to present, the submission dates are December 1 of 2025 through February 28 of 2026. And the date that our data specialist last refreshed that data was March 12 of 26. So any claims for those dates submitted after December 12 won't be included. And remember that I looked at Specialty 68 for clinical psychologists, and I chose all codes. I wanted to see all of the data. I want to show you real quick here, and I need to open it up. So bear with me. I'm opening it on a second monitor that I have open, and I'm going to pull that data dashboard over so you can take a look at it. Let me make it a little bigger here for you. All right, little bigger. All right, what I want to show you is those data slicers that I talked about. I told you I'm looking at all jurisdictions of WPS, so both J5 and J8. I'm looking at Part B only claims. I can choose to view unprocessable claim information, which is rejected claims, denied claims. I can choose to look at all specialties out there by using this eraser, or I could choose a particular specialty code, that 2-digit code for clinical psychologists. I can choose to look by state if I'd like. I can choose to look by counties, and only part of these are populating. Or I can choose to look at a single CPT code. I'm going to choose 99. Clinical psychologists won't bill that. Let me choose another code here, 90791, just to show you and demonstrate how quickly, at the click of a mouse or hitting the enter key, we can view the data. It's all there. It's a dashboard. Our Insight team, which is our data team, pulls this data, puts it out there, makes it available. And as you can see, the data that I'm looking at now on this dashboard are submission dates January 1 of 2026 through March 31 of 26. You know, each month they add a new month of data, they take away an old month of data, and you can see that the data was last refreshed on April 6. So the data that I'm looking at, or I'm providing for you today, during this webinar is data from claim submission dates December 1 through February 28 of 26. And the reason why it's older data is because I had to pull all of this information together to create your presentation materials, your handout. And you'll notice in your handout that I've included many embedded links. If you see something that appears to look like it's underlined and in blue colored font, that means for that electronic file that you downloaded, you can simply click on it and you'll go right to that embedded link, typically to the resource that I'm cited on the particular slide. So here then is the actual data for the data slicers that I use to pull data and analyze data to present you with education today to fix or avoid these top reasons for rejections and top reasons for denials. Now you're going to see these listed in descending order, and we're starting out with rejections. Remember, rejections are not adjudicated. You will receive that remittance advice. You need to fix it, resubmit it. The number one reason we rejected Part B CMS 1500 issued claims or submitted claims for clinical psychologists during that time period I mentioned was that the rendering physician number was invalid or missing. How do you fix this? You look at that number and you see what was entered. Is it invalid? Is it missing altogether? You need to fix it and resubmit it. Similarly, the number 2 reason, most common reason we rejected Specialty 68 claims was invalid or missing modifier. Look at the claim you submitted. Was the modifier there? Was it valid? Was it a modifier that was not needed? That's what you need to determine and fix it resubmitted. The number 3 reason we rejected claims is that field 11 on that claim form, or the electronic equivalent, must be completed. This is a field on the electronic claim or on the paper claim that asks you, is there another insurance primary to Medicare? If the answer is no, you can't leave it blank. You have to put something there. So our education is that you should put the word none there. If that is left blank, your claim will reject, and you'll need to fix it, resubmit it. Incomplete, invalid plan information for other insurance is the 4th most common reason. That means you told us there's another insurance, but you didn't give us all the details that the claim requires. Okay, I'm going to share with you later how you could fix or avoid these. So I'll be giving you some tips and providing you with resources to avoid each one of these or fix these. Number 5, missing, incomplete, invalid billing provider primary identifier. The next most common reason, or other most common reasons, is that the claim must be submitted to RRB. And if you look in the notes section of your handout for this slide, you will see that RRB means Railroad Retirement Board. If the beneficiary is an individual who is retired from the railroad, then his or her claims must be submitted to the Railroad Board Specialty Contractor, which is Palmetto GBA. WPS does not process claims for railroad retirees, are those folks that are eligible for Medicare and retired from the railroad. Invalid, incorrect diagnosis code is another common reason we reject claims. Treatment rendered in an inappropriate or invalid place of service. And finally, facility, laboratory name and address or PIN is not missing, or is missing rather. Sorry about that. I thought it would be interesting to tell you not just the reasons why we are rejecting your claims and denying your claims. I'll go over those later. But here in descending order are the top 5 codes that we rejected on Part B claims submitted by clinical psychologists. Number 1 is the 90834. This is individual therapy sessions, 38 to 52 minutes. Used by licensed clinicians to report that face-to-face therapeutic dialogue or behavioral modification with their patient. 90837 is the 2nd most commonly rejected code by WPS, and that's individual psychotherapy, 53 minutes or longer, typically 60 minutes. 90791 represents that psychiatric diagnostic evaluation without medical services. This is that code used for the service when you evaluate your new patient and establish a diagnosis code and create that treatment plan. 90832 again is another individual psychotherapy code. This one 30 minutes or 16 to 37 minutes. And finally, 96136. This one's a little bit different. This is used by psychologists or other qualified health professionals to bill for the first 30 minutes of face-to-face psychological or neuropsychological test administration and scoring. It does require the administration of 2 or more tests, and it's used in settings like outpatient clinics. Let's look at the codes individually and see the reasons why we are rejecting them. 90834, individual psychotherapy. These are the code. I'm not going to read through all of these right now, but I'm giving you the specific reasons why this code rejected. I already talked about the most common reasons overall, and now I'm talking about for this specific code. Why are we rejecting that code? Similarly, the 90837, I'm going to flip back one slide just for a moment. You'll see that these are pretty much the same reasons. They're just in a different order because the order I'm presenting is the first sub bullet there shows you the number one reason why we rejected the 90837. The second sub bullet here is the number two reason, so on and so forth. These are all reasons we talked about earlier. The 90791, it was rejected because of an invalid or missing modifier. The claim must be submitted to the Railroad Board specialty contractor, and because there was incomplete invalid plan information for other insurance. That's the top reasons for rejections. 90832 is another individual psychotherapy. You can read through those. And finally, the 96136, which I am going to talk about just for a little bit because it is, a different kind of service than the other four. It's that psychological or neuropsychological test administration and scoring. You can see why we rejected it, invalid or missing modifier. Again, field 11 of that claim must be completed. You can't leave it blank. If there is no other insurance, primary to Medicare, you need to put something in there, and we suggest, or our education is that you put the word none in that field, or the electronic equivalent. The third sub-bullet is the same as we've talked about before, but the final one there that I've listed, and there are other reasons, of course, why we rejected that code. These are just the top reasons. This one's a little different. The patient or insured MBI, which is the Medicare Beneficiary Identifier, and the name do not match. That means the MBI on the claim and the name do not match exactly in the records. Let me give you an example of that. If you are looking at the beneficiary's Medicare card and you look at the MBI on that card, it has to match exactly to the name on that card that you put onto the claim form. So if on the Medicare card where it shows that MBI, there is a name with a middle initial, if on the claim form you don't put the middle initial, that's going to mean it doesn't match. So your claim may reject. You need to fix it, resubmit it. Here are the top 5 reasons for denials now. And remember, denials are different. Most denials have appeal rights. There's different actions you can choose from to fix them. But the number one reason why we denied claims, submitted Part B claims, 1,500 claim forms specifically, that were submitted to WPS for the time period that I identified earlier is right here on this slide, and these do appear in descending order. The number one reason we denied clinical psychologist claims during that 3-month period was collection of fee-for-service during periods of managed care. Well, that's a little bit cryptic. We understand that some of those reason and remark codes that print out on your remittance advice can be a bit cryptic. WPS does not maintain those codes, those reason and remark codes for CMS. It is another contractor. I know we will fairly often get a phone call in customer service when we're asked, can you change that code? It's a little cryptic. We cannot because we are not that contractor. The CMS website includes information about reason and remark codes. The company that is the contractor to CMS for that is the Washington Publishing Company, and they do have contact information available should you wish to contact them to ask them to change a reason or remark code. Just a little tip there. So I asked our system folks, does this really mean what I think it means when I read collection of fee for service during periods of managed care? And yes, it did. And what this means, and what I asked them, does this mean this, is that this particular beneficiary has elected managed care. They have elected Medicare Advantage or Part C. So Medicare Part AB should not pay or process claims for that particular benefit. They're denied. Collection of fee-for-service during periods of managed care is what that means. The patient is a Medicare Advantage enrollee. Look at number 2 and then look at number 5. Duplicate charge paid. There'll be a date on that remit, on claim, and there'll be an internal control number that identifies the claim that was the duplicate for the service being processed. So there's a duplicate charge already paid on another claim. Look at number 5, duplicate charge of a claim, and it will provide that identifier, the ICN, now being processed. That means 2 claims in the claims processing system the same time for the same thing. So the claims processing system, which for Part B is the multi-carrier system, or MCS, will recognize 2 of the same services in the system at the same time, and it will deny one as a duplicate. Now, let me say this. This is the number 2 and number 5 reason for denials. And your specialty is no different than any other specialty. We continue to receive, process, and deny claims every single day, thousands of them that are duplicates. And we really need to work on eliminating those duplicate claims. And I'm going to tell you why. Think of it this way. If you prepare and submit a claim to Medicare, that's a cost, right? Cost you money. Then we reject or deny a claim, that's a cost. And then you fix or have to request an appeal for that rejected or denied service, that's another cost. And then it comes back to us for that appeal or to reprocess the rejected claim, that's another cost. Think of how much a duplicate charge costs Medicare, and think about how much it costs you or your organization, your billing entity, your provider, so on and so forth. Thousands of duplicate claims are being denied every single day. I'm going to talk about ways to avoid that later on. Number 3, this physician or supplier is not eligible to receive payment. That's a provider eligibility issue, right? Whoever billed for it's not eligible to receive payment. The time limit for filing your claim has expired, no appeal right. That's the number 4 reason we denied clinical psychologist claims. You have 12 months from the date of service to submit a claim to Medicare. If you submit a claim for a service outside of that 12 months, your claim is going to deny for timely filing. And there is no appeal right. This is one of those exceptions I talked about earlier. Typically, the remittance advice is going to say you have a right to an appeal. But for this denial, a timely filing denial, there is no appeal right. Medicare will not pay for this service for this condition. This means policy. Okay, we're not going to pay for the service for this diagnosis. That's a policy, that's coverage. Okay, that is medical necessity. That means consider presenting your patient with the ABN if you believe Medicare may deny that service. Okay. Next, provider not, there's a typo there, I apologize for that. Provider not eligible or certified for this procedure for this date of service. That's a provider eligibility issue. The next most, or another top reason for denial is procedure must be billed with the primary service. That means that you submitted an add-on code. Some CPT codes are considered to be add-on codes on your claim, but you didn't bill for the primary service along with it. Okay. Next, the claim must be sent to the EGHP or LGHP first. If you look at the notes section for this slide, EGHP is Employer Group Health Plan, and LGHP is Large Group Health Plan. So that means that Medicare is secondary for this particular patient, or that the Medicare records, those records in the common working file that are sent over by specialty contractors or by Social Security, those eligibility files for the patient show that there's another insurance that's primary to Medicare. And your Medicare claims will be denied in that case because you have to send the claim first to the EGHP or LGHP. And finally, these services denied because the patient is in a hospice. Some patients elect to choose hospital coverage, which means most of their services related to their terminal illness do need to be processed by someone other than the MAC. That would be the home health intermediary, or the home health hospice MAC rather. All right, let's look at the codes. Again, in descending order, these are denials. You will see 1, 2, 3. The first 3 are codes for individual psychotherapy. And then you will see 90791 showing up. That is that psychiatric diagnostic evaluation without medical services. And lastly, the 96133. This is an add-on medical billing code for each additional hour or partial hour, typically at least 31 minutes of neuropsychological testing evaluation services that are performed by a qualified healthcare professional. So let's take a look at each of those codes, just like we did for the rejected codes. And here, 90837, the number one reason we denied it is because the patient has Medicare Advantage and the claim came to a MAC, a Medicare Part A B contractor is a MAC. Medicare Advantage, of course, would be your Part C plan that you would submit to for those beneficiaries who have selected or elected rather a Medicare Advantage plan instead of traditional or original Medicare. Number 2, physician supplier not eligible to receive payment. So that's an enrollment issue, an eligibility issue rather for the physician or the provider, in this case the clinical psychologist. Third and fourth reasons we denied 90837 is because it's a dupe, it's a duplicate, and because the claim must be sent first to the EGHP or LGHP. And I'm not going to read through all of these once again. You can come back to them, but they really are just kind of a mix-up of the things that we've already talked about. So individual psychotherapy again, and again, and then the 90791. And I do want to talk about that because we get a lot of questions about the 90791 and the 90792, which of course you're not billing for, clinical psychologists don't bill for, because that is with those evaluation and management services included. So the 90791 is that diagnostics evaluation based on our local coverage determination or our LCD policy. This service is considered medically necessary once every 6 months per episode of illness. However, if reported more than once per episode of illness, documentation will be required for the establishment of medical necessity. Now, in addition to our policy that states what I just said, we do have our billing and coding article A57480, and it states that this service can be conducted once at the onset of an illness or suspected illness. The same provider may repeat it for the same patient if an extended break in treatment occurs, if the patient requires admission to an inpatient status for a psychiatric illness, or for a significant change in mental status requiring further assessment. The coding and billing guidelines also says that WPS considers an extended break as approximately 6 months from the last time the patient has seen or been treated for their psychiatric condition. It goes on to say that the code may be utilized again if the patient has had a previously established neurological disorder or dementia and there has been an acute or a marked mental status change or a second opinion or diagnostic clarification is necessary then to rule out additional psychiatric or neurological processes which may be treatable. So 90791 is one of the top denied codes, not just for clinical psychologists, but for other mental health providers. But the reasons why they're being denied for your specialty are here. It is that frequency denial that's really kind of crossing all specialty codes for this code, and then the 90792. If there, and this is a hard-coded edit in the claims processing system, which means that when that code is recognized during claim processing, the system is going to look to see that another service was not also submitted and paid within the last 6 months. It doesn't matter if it's a different provider. This code is only payable once every 6 months. Like I said, hard-coded edit. Now, there may be situations, and I just talked about them, where the service can be done more than once, but you'll need to request an appeal and send your documentation that shows why it was medically necessary to do this twice within a 6-month period. Okay, we do recognize the difficulty in knowing that your patient has had this service even by someone in another clinic or across town. Maybe it's a patient who's moved. It is difficult to tell that. There are self-service options to tell you the last date these services were provided. You can use those. Any service that has the frequency, you can use those self-service options, but we recognize it is often difficult to know that there wasn't another service within the same 6 months. Ask your folks that are on front end, those that see the patients, have you seen anyone else? Have you gone to another doctor? Have you, had another service rendered? Do you always have your services here at this clinic? Do you see someone else across town? Ask those kinds of questions, and hopefully that will be helpful. We do understand it's difficult at times to recognize this. 96133 is the last of those commonly denied codes that I've included, and here are the reasons that this code denies. Nothing new. These are all reasons we've talked about already. So now I want to talk about ways to fix or avoid. I've got a lot of information here. We don't have time to go into all of this in detail, but I want you to know where you can go for help. For rejected claims, there are requirements for claims processing, for completing the forms, the CMS 1500 claim form, the 1450 claim form. I'm focusing on that 1500 claim form today. There's also EDI, or electronic data interchange, electronic claim requirements when submitting your claims to Medicare. And these are the chapters in the Medicare Claims Processing Manual that tells you what is required on those claims. So when you see that a claim is rejected because something's missing or invalid or incomplete, that means that these claim processing instructions tell you what you need to have there, so how you fix it. Now, we know that most of you are submitting electronic claims. So our electronic data interchange staff has actually created this cross-reference guide to help users become compliant with the electronic claim submission requirements. So this crosswalks from the CMS 1500 paper claim form to the 837-5010 electronic version, which is currently being used. So when you're looking at this particular tool, if you will, I'm going out to the WPS web page and I'm going to pull it over. Doesn't matter which of the jurisdictions you're in. I'm just going to select upper right here, MAC Part B. We're talking B today, Iowa, Kansas, Missouri, Nebraska, but it works the same way for Indiana, Michigan. Accept the licensure agreement. If you're on the WPS website, this is our home page. You can scroll down a little bit. I've made it bigger so that you can see it easily. Over here under quick links, you will find EDI, which is electronic data interchange. When you choose that, you leave the WPS website and you go to the WPS EDI website. Scroll down. We have our Medicare division. We also process claims for TRICARE. And we also have our commercial insurance. We're talking Medicare, so you want to choose Medicare EDI. And you will see here there are various guides, tips here for billing electronically. But what I want to point out, and I've included embedded the link in your handout, is under resources. Here's that crosswalk. And when you open it, you will see the crosswalk itself. And if you think of a paper claim form, you'll know that it has item number 1 on the claim, what you need to put there. Well, this does the same thing. It says item number 1 on the paper claim. It's the type of health insurance. And here it tells you on this crosswalk where you need to put the information on the electronic claim form. It tells you the data element description. It's the claim filing indicator code. It tells you requirements for the version 5010. What's the format you have to use? Let's look at patient's date of birth, number 3 here. Tells you how you have to enter the format. Remember that I said something's invalid, your claim is rejected, maybe it wasn't submitted in the right format. These are the things you need to look at. Another important thing on this crosswalk is this status column right here. Okay, I'm trying to just show one column, but see these R's? Well, some of them have S's. Well, what does that mean? R means that it's a data element that's needed in order to process your claim. In other words, if it's not there and it's needed to process your claim, what's going to happen? It's going to reject. Okay? What does an S mean? It means any data element that must be completed if other conditions exist. Okay, so think about this for a minute. You told us there's another insurance, but did you fill out all those other item numbers or loops, data elements that are required on the claim to tell us about that other insurance that's primary to Medicare? So this is why this is important. You'll find out what you need to put on the claim and what format. And see this blue colored font with the what looks to be underlined? That is that link I'm talking about. So if I go there, or embedded that link, if I go there and click on it, it will open that resource. Provider eligibility for rejected claims, even denied claims at times. You need to make certain that the provider identifiers that you're reporting on the claim are correct. They're in the correct format. You need to make certain that you're identifying a rendering provider, an ordering provider, or a referring provider. Make sure you're keying them correctly. Make sure you are aware of the eligibility dates in your provider enrollment records, because sometimes we have to reject or deny claims and it's based on that date of service doesn't match the eligibility dates in our files. So something to keep in mind. We have provider eligibility. We also have patient eligibility, and I talked about one of those earlier. Patient name has to match that MBI. If your patient is enrolled in hospice, you need to submit the claim elsewhere or consider which services can or cannot be submitted to the MAC, and I'll show you where you can find that resource later. You need to make sure you're submitting to the correct payer. If the patient is a railroad retiree, send it to the Railroad Retirement Board Specialty MAC. If they have selected or elected Medicare Part C instead of traditional or original Medicare, you need to send it to the plan. I'm going to pause just for a moment. All right. Next, modifier issues. If there is a required modifier, make sure it's there. Make sure that the modifier you're choosing to report is one that can be used with that CPT code. You can call customer service and say, does your system accept modifier, and tell us the modifier, with CPT code XYZ. You can ask that, but what you can't do and shouldn't do is call them and explain the patient came in for XYZ. We did this, we did that, then we did this. Can I use modifier X, modifier, give us the modifier with the procedure. You can't give us a billing scenario, but you can ask us, does your system accept? Now that doesn't guarantee payment, but it's going to tell you whether that claim is going to make it through the system or whether it's going to be rejected. Okay, something to think about. Make sure that the modifier you're reporting is valid for the date of service. Duplicate denials, make certain that you don't automatically resubmit a claim before you establish the status for that claim. What we're talking about here, folks, is those situations where providers will automatically submit claims every 30 days if you haven't gotten that EOB notice. Or you haven't yet looked at the EOB notice. That Medicare summary notice is the beneficiaries, but I'm talking about your statements from Medicare. Your remittance advice, I used the wrong word there, I apologize. So make sure that you're looking for that remittance advice. Establish the status. You can use SNAP, the SecureNet Access Portal. Make sure you're billing appropriately and always identifying modifiers, because sometimes a modifier tells us, or tells Medicare, this is a repeat service by the same provider. Then we know it's not a duplicate, okay? And then your claim won't deny as a duplicate. Use that IVR, use the SecureNet Access Portal. IVR, of course, is the interactive voice response system that you can use to check status of a claim. These are really costly to everyone. If you auto-submit before establishing status, or you use a billing service that resubmits claims for you, tell them to stop and stop doing that. It is considered an abuse. Continued abuse may be looked upon as fraud. MSP denials, what I'm talking about here is those Medicare secondary payer denials. There is a fact sheet, questionnaire, web page, and we have a MSP YouTube channel playlist that provides a lot of great education. I can't possibly dive into MSP education today, but if your claims are denying for that reason, these are helpful resources that you can use to avoid those in the future. A lot of great information out there about MSP. We do recognize the difficulty when the information that's coming over from another contractor doesn't get there before your claim's processed and something is changed in terms of eligibility for that patient, but you can check eligibility using some of the tools we've already talked about. Timely filing of claims. I talked about this earlier. You have 1 year to file that service after the date of service. Claims are going to deny based on timely filing. And, you know, if you don't submit that in timely, obviously, and these do not have appeal rights. Providers who have reason to believe or have good cause that they can have Medicare waive that timely filing because there's a reason why that claim was submitted, wasn't submitted timely, can submit a request to waive timely filing to the WPS claims manager. But for those situations where timely filing was due to a third-party error, it does not qualify for waiver of timely filing, and we cannot reopen the claim. I will show you a resource really quick here that speaks to that. It is on the WPS website. Pulling it over for you. Go to the WPS website homepage. You'll see that when I search timely filing claims pops right up, that predictive search that we have available in our search engine. This is where it tells you that if your claim was not filed timely because of another insurer that may have recouped their previous payment, and that's what caused the delay. It's right here. CMS does not accept this as a reason to reopen your claim. It provides you the language from the IOM, the Internet Only Manual, that says MACs cannot reopen that claim if the reason for timely filing is due to a third party. Okay, so this is why we will not reopen timely filing if another insurer comes back even 3 years or 6 years, 7 years later and recoups their money. We cannot reopen the claim or waive timely filing. All right, moving on. I talked a little bit about managed care. If a patient selects or elects to have Medicare Part C, we don't process claims. We can't answer questions about that patient's claims. We can't answer what's covered and what's not covered. We can't tell you what the fee schedule is. You need to contact the plan. We have information available out on our YouTube channel that I'll show you in just a minute, which shows you where you can go if you want to look at or watch a video that speaks about denials that are due to the fact that a patient has Medicare Advantage. So you're going to want to confirm eligibility for your patient before you submit the claim to Medicare. There is a resource here. This is a CMS resource publication here that provides for you some information about the differences in coverage. The resources I'm going to show you includes a link to that YouTube channel, or YouTube video rather, about Medicare Advantage. For rejected claims, we have a resource on our website that includes those reason or remark codes that you'll find on your remittance advice. If you see a code on your remittance advice, go out to this article, find that code. It tells you how to fix it. We also have a YouTube playlist for rejections and denials. Use SNAP to look for and verify patient eligibility. That's the secure site of our website. There's also a helpful CMS publication that I've listed here for you and embedded. If you're looking for information about billing services while a beneficiary is in a hospice election. Uh, there is a resource available. It's linked here. It includes information about that election, how payment is made, the modifiers to be used, what place of service you should report on those claims, and has links to other resources. Modifier help. We have a modifiers webpage that includes links to many modifier fact sheets. If you are on the WPS webpage, the easiest way to get to it, I'm going to show you. And, I've linked to it here, but if you're on the website and you need to go to that information, go to the search box, choose modifiers. There it comes back. Right here's our modifiers webpage, and if you scroll down, you will see many, many links to fact sheets, provides you with a definition of the modifier, appropriate uses, non-appropriate uses, or those uses that are not appropriate, and even some additional information that's helpful. So a lot of great information in those fact sheets. We also have a modifiers playlist on our YouTube channel. Similar to that article we have for rejections, we have one for denials, but this time we've arranged them by category. We have bundling denials, we have duplicate claim denials, entitlement denials, that's your beneficiary entitlement or your provider entitlement, payer contractor, is it railroad board, is it Medicare Advantage? But here we've arranged these by denial category, and then we've also included those reason and remark codes so that you can avoid those denials in the future, or submit your appeal appropriately, include the information you need. Here is information on how to request a clerical error reopening. You can do this self-service by using SNAP. This is a great article that says this is the definition of a clerical error reopening, and it tells you what corrections can be processed as this clerical error reopening, which can't. You do have a time limit for requesting these. It's 1 year from your initial remit notice, and you can submit these using SNAP. You can do it yourself and make them corrected much more quickly if you use SNAP to do it yourself, but there's other ways to submit these, and it's all included in this article. We do have, or CMS has on their website, an appeals process flowchart that shows all 5 levels of appeal. You'll see them labeled on that particular flowchart. Let's see if I can get this to open up while I'm talking about it. This is one of my favorite resources, and the reason why I like this so much, it's going to open here in just a minute, is that it tells you how many days you have to file the request for each of the 5 levels. Make this bigger for you. So it shows the initial claim being processed. You have 120 days to file a first level appeal. The MAC has 60 days to make their decision. Then you have 180 days to file a second level appeal if you do not agree with the MAC's predetermination notice, and so on and so forth. The qualified independent contractor, sometimes called the QUIC, it tells you that's the second level of appeal, includes those timeframes. There are 2 levels of appeal. The third level, which is the ALJ hearing, Office of Medicare Hearings and Appeals, and Federal District Court or Judicial Review, which is level 5, that have an amount in controversy. That is the minimum dollar amount threshold that you have to meet in order to submit to that level of appeal. Now, one thing that's new to a lot of providers that I talk to is that you can combine multiple claims to meet that threshold. So if you have a similarly denied claim, even though it's for another patient, you can combine them and meet that threshold. The amount in controversy it shows here is greater than or equal to $200 for level 3. The amount in controversy is greater than or equal to $1,960. And make sure you're looking at the date on the bottom of this flow chart. CMS does update them, but it tells you the amounts by calendar year. Those amounts in controversy will sometimes change. Now, the only level that doesn't have a time frame for getting their determination back to you, which is in a letter and you'll receive the remittance notice, is federal judicial court. There is no limit that they have to provide you with a response to your appeal request. And mostly that's because of that calendar used for federal judicial court. Other help, there's an interactive map on CMS's website that says who processes what claims for which states. There's a place of service code set, which will tell you the appropriate places of service Medicare uses on claims. There are add-on code edits that tell you which are those codes that you cannot report before reporting a primary service. So I've included that here. And then we have an ICD code list web page as well that provides those code lists for ICD-10. Really quick here, we do have this information to share with you, and I'm going to make it really short. If you find an overpayment, or you discover an overpayment, or you happen upon an overpayment at your place of business, one that we've not asked you for, there's a couple of ways that you can set up a request for us to ask you for that information. You can return the refund on your own, or you can ask us to ask you to send that money back to us. This is when you self-discover an overpayment. There's a couple of ways to do that. To return those funds or set up notices, you can use SNAP, which is Self-Service Secure Net Access Portal. That's on our website, or you can use paper method for that, and I've included some embedded links for you here to do that. Our folks that work with overpayments asked us to share this information with you. We don't have a whole lot of time for question and answers. I'm going to ask you real quick, Karen, have we received questions today in the chat, or have no questions been submitted?
Mary, we haven't gotten any questions.
Okay, well, I'm willing to take your questions. I'm going to tell you in just a minute how you can submit them, and I will get a response either back to you individually, or I will create a list of questions and answers and send them out to everybody. I just thought I'd see if we've gotten any questions thus far. I did get those pre-submitted questions, and this is exactly why I like to get those in advance, because I can work the answers to those questions into my prepared remarks. When you disconnect from the webinar, you're going to be directed to a CMS survey. I'm also having Karen add a link in the chat. I really hope that you take a moment to provide feedback on how I did today. If you're watching this video as an encore, you will see a pop-up at the end of the webinar with a picture that says survey. The feedback we receive really does lead to changes. We have made changes to our education based on your feedback, and we've gotten some great response on that. People are happy that we made those changes based on what they've submitted in these particular surveys. As you can see, your opinion really does matter because we are making those changes continuously. After disconnecting today, you should receive a thank you for attending email, and it will contain contact hours that you can submit if you want continuing education units. WPS does not request them for you. You will need to submit that email you received, and it's in the body of an email. There's no separate attachment that contains the verbiage that says you participated in this event. We call it our certificate of achievement. However, if you joined only by phone, in other words, you're hearing me but you're not seeing my slideshow, WebEx is not going to generate that email. So then you're going to need to contact us, because these emails post webinar go out from WebEx, our webinar platform. They don't come from WPS. So first of all, look for that. If you don't find them, you might want to check your spam or your junk, because your employer may send those kinds of emails to spam or junk. But if you need the certificate of achievement and you join only by phone, in the chat, Karen's going to add a link to our education mailbox. You heard me talk about that at the very beginning of our program, and it tells you what information you need to send us in order for us to send you an email with a certificate of achievement in that in the verbiage in the body of the email itself. Now, if you think of any questions, those can be emailed for up to 7 days following today's event. Send them to the email address that Karen has placed into the chat. That's our education mailbox. And in the subject line, place Rejections and Denials, Clinical Psychologists. Then the staff member that's looking at the email will know to forward those emails to me so that I can get a quick response back to you. And this brings us then to the end of today's presentation. On behalf of myself and Karen and all of the provider education team, I do want to thank you for being here, and I hope that you will join us for future events. Thanks, everyone. You may now disconnect.